continue the way it is on the schedule. So at this point, before I introduce Dr. Thomas Kelly, who is the founder of the heart surgery program at our hospital here back in the early 80s, and been very, very active and doing a great job for our program. But he's also at the same time elected member of the board of the Sarasota Memorial Foundation, which he has been already supporting the program and also supported by the community. And he would like to give just a few words and then have Tom come in and express your thanks to the community and everybody else on behalf of the foundation. I'm not going to give you a speech. Come on. you are the official member of the board. So Tom Kelly is coming up here. While we're doing that, I wish everybody can take place now so that we can start. Mark Pohl, are you ready? As soon as Tom Kelly gives a few words, he will be next introduced, and we'll move correctly. All right? Here, you don't even have to go up. Okay.
Thank you. As a member of the foundation board, I'm very happy to be here with the group and know that the foundation is now supporting the program that we're now enjoying today. I think it's very important to realize that the foundation is one of the major supports of the hospital, and they have provided many, many different things, including starting the open heart surgery program at Sarasota Memorial, sponsored by the foundation through the Sudikoff family. And they were able to support the program that I was fortunate enough to start in 1983 with a generous donation of $500,000 to buy equipment. And since that time, the Sudikoff, both Roberta and Harry, who are the Sudikoff members, have continued with their foundations because both of those people have passed. But the foundations continue to support the hospital, which the foundation is very grateful for. So thank you all, and thank you all for coming to a great program.
Thank you, Tom, and also now we have extended the thank you to the board. Now, there was a talk this morning with which Dr. Mark Pohl was kind enough to agree, and then just started late this afternoon. Dr. Mark Pohl is from the professor of the Cleveland Clinic. He was the chief of the nephrology section there, have long-standing interest on the heart, hypertension, the kidney, and the talk will be the cardiorenal syndrome. Mark Pohl, 15 minutes, no excess.
Thanks,
okay?
Mahfouz.
All right.
Well, you move me from the morning to the afternoon. He's cutting my, he does that every year. We'll see how this works. Anyhow, thanks, Mahfouz, for inviting me back again. Usually I give 2 or 3 talks, but he figures I'm getting too old to give 3 talks. So I'm doing 1. And it's a daunting task to be flanked by Tony DeMaria, Nett Wenger, and Bill Roberts, but I'll do my best. And I'm going to talk about a subject called cardiorenal syndrome. Now, this is a troublesome term, and there's really no universally accepted definition of cardiorenal syndrome. Probably depends whether you're wearing your cardiology boots or your renal boots. For example, is this cardiac disease which causes renal failure? Is it renal disease which causes cardiac failure, like in acute post-streptococcal glomerulonephritis? Is it bilateral atherosclerotic renovascular disease, which may be associated with flash pulmonary edema and progressive renal insufficiency? Is it somebody on dialysis? Because as you see at the bottom of this slide, 36% of them, I don't know if this thing works, if someone will show me. 36% of dialysis patients have a history of heart failure, so should they be called cardiorenal syndrome? And 25% of patients with heart failure have renal insufficiency, so should they be called cardiorenal syndrome? And that case that Dr. Valentine presented this morning, probably the most important piece of information on it, was sort of ignored until the end. That patient had that woman had a creatinine of 1.8, which gave her a GFR of probably 25 to 30, and we don't even know why. Maybe she had cardiac amyloid, and then all those fancy things that one would want to do would be of no use at all, because no one bothered to see if she had any protein in her urine. So that would be an example of cardiorenal syndrome. So I'm trying to lay out the groundwork as to how muddy this could be in terms of defining it. Well, a number of years ago, the NHLBI working group defined the cardiorenal syndrome, as you see in yellow, as the extreme of cardiorenal dysregulation, whereby therapy to relieve congestive symptoms of heart failure is limited by further decline in renal function. I sort of like that. That's a one-sentence definition, but they went on to include in their definition something about prognosis, which ideally isn't part of a definition. A poor prognosis with oliguria, hyponatremia, we'll come back to that, persistent edema, and diuretic resistance or refractoriness. Now, a number of years ago, the heart failure people in Cleveland had what they called a cardiorenal club. I think when Gary was with us, I think Gary may have started that, Gary Francis. And they would meet regularly at dinner meetings, and somebody would sponsor it, and they would get elegant speakers to come in and talk about it. And one day they decided they would have a session on cardiorenal syndrome. So we spent about an hour, nephrologist, cardiologist, heart failure specialist, trying to agree to a definition. And finally, one of our guys, I'll never forget it, Rob Hobbs, who's now retired, was the head of our heart transplant program at the Cleveland Clinic, said, look, you're just wasting your time. There are only 4 features of cardiorenal syndrome: heart failure, fluid overload, resistance to diuretics, and progressive renal dysfunction. By that, I mean a decline in GFR. So it became my habit after that, when I would see a patient that had an elevated creatinine, which was deteriorating, and had fluid overload, if I thought the patient met these 4 criteria, my note would say, this patient has cardiorenal syndrome, heart failure, fluid overload, resistance to diuretics, and progressive renal functional decline. And by renal functional decline, we're going from your right on the bottom, that's the GFR, to your left, which is where the 2 with the abscissa and the ordinate cross, that would be a 0 GFR. And then you see when you get to a GFR of about 40 to 50 in the middle of the abscissa, I can't get the pointer to work, the curve steeply rises. The curve steeply rises. So you have this patient that was presented this morning by Dr. Valentine with a creatinine of 1.8, and he said the GFR might be about 25. That person is on the steep part of the curve. Well, all you'd have to do is tickle the kidney, just sneeze on the kidney, and that creatinine would shoot right up to 4 or 5. And then cardiologists call the nephrology guys to bail those patients out and dialyze them. It's not that their GFR got so much worse. It's that that lady started out at the time of the presentation this morning with a GFR of 25 to 30 at best. So she's right on the steep part of the curve with her creatinine of 1.8. And all you got to do is touch those kidneys and that creatinine shoots up to 4 or 5. That's a cardinal principle of renal physiology. And that's why we have so many of these people with heart failure whose serum creatinines fluctuate up and down, up and down, and up and down. Now, an elevation in the creatinine is not a good thing in terms of heart failure outcomes. So this slide shows you the effect of worsening renal function on outcomes in patients with acute heart failure, the outcomes being heart failure hospitalizations and cardiovascular mortality. And on the ordinate, you see the proportion with event-free survival. You see the blue line as a 55% event-free survival, and the yellow line, the bottom line, as a 28% end-free survival. The bottom line is when the serum creatinine went up by more than or equal to 25%, or the serum creatinine increased by more than or equal to 0.3 milligrams per deciliter. The blue line, the top line, which is not as good, the serum creatinine increases by a little bit more. So it's not a good idea to have your serum creatinine go up by more than 0.3 milligrams per deciliter because there's a markedly decreased survival. Now, last year, Mahfouz asked me to talk about how do the kidneys react when there's a bad heart. So the kidneys are sitting there minding their own business, and they look out at this circulation, and they perceive a contracted or inadequate or redistributed blood volume, or sometimes they perceive a contracted extracellular fluid volume. Doesn't mean it is contracted, but the kidneys think it's contracted. We're going to come back to that. In fact, as you all know, the total blood volume and the extracellular fluid volume are expanded and or redistributed, and the kidneys respond as if the circulation is compromised. And that has led to all of these terms that you've come to know and love. But if someone were to ask Dr. Cohen to give a half-hour lecture on what is the effective circulation, even Jay, who's defined a lot of this stuff, might struggle with these terms. Maybe you'd come to the conclusion the circulation is vasodilated or there's decreased compliance. And so the kidney acts as if it sees not a full arterial tank. The late Don Selden used to talk about the effective arterial blood volume. They got this blood volume sitting there. The kidney doesn't care what's on the venous side of the circulation. The kidney only responds to what it sees on the arterial side of the circulation. And Dr. Selden would call that the effective arterial blood volume. And then he would call that a distributory perturbation. In other words, in heart failure, a greater fraction of the circulation is shifting to the venous side. So the kidney looks out the window and it sees an inadequate arterial circulation, and all sorts of things happen. Primary versus secondary aldosterone, increased filtration fraction, and neurohumoral responses. And we're going to go through some of these. And so you all know that what you measure when you look at the patient's chart or when you look at the laboratory tests that get reported, you see a reduced urine volume, often oliguria. The kidney is responding as if the patient had a gastrointestinal hemorrhage, often oliguric, edema, a disproportionately elevated BUN to creatinine ratio, a reduced fractional excretion of sodium, a reduced random spot urinary sodium, which is only good, by the way, when it's a random urine oliguria and not just been pumped with a diuretic. An increased urine-specific gravity or increased urine osmolality. Then the renin-angiotensin aldosteronism is cranked up. That's called secondary aldosteronism. Increased catecholamines, increased vasopressin, and hyponatremia. And we'll come back to hyponatremia at the end. So now let's talk a little bit about renal physiology. This morning we talked about cardiac pathology, and this is one of your favorite slides, I hope, that you probably suppressed. And you see these sites in the nephron going from your left, which is the glomerulus, down to the bottom right, which are those drops of urine starting to form in those dashed lines. So the filtrate of plasma comes across the glomerular capillary. I don't know how I can get this moving here. Here we go. So the filtrate comes across the glomerula here into the proximal tubule. I want you to remember the proximal tubule. And that filtrate of plasma has sodium, chloride, bicarbonate, all the other goodies, filters its way down here to the thick ascending limb of the loop of Henle. This is where the loop diuretics work, where normally chloride and sodium is reabsorbed and water is left behind. And I want you to remember this. This is the early distal convoluted tubule. This is where the thiazide diuretics and chlorothalidone work. This is where aldosterone works. And this is other areas where aldosterone and vasopressin work. So these are the sites of tubular sodium and water reabsorption. 60 to 70% in you and me get of the filtered load of salt and water at this spot right here gets reabsorbed in the proximal nephron. Then maybe another 10% of the sodium filtered load gets reabsorbed here. Another 10 to 15% gets reabsorbed here. Another 5 to 10% gets reabsorbed here. So if 27,000 pieces of sodium get filtered, you only end up with 150 milliequivalents of sodium in the urine. So there's a lot of sodium reabsorption going on in these sites of the nephron. Now, filtration fraction doesn't have to be such a difficult concept. This is the proximal tubule. This is the afferent arteriole. In heart failure, the renal blood flow is reduced. And so here's the blood flow coming at the nephron right here. And there's a relative to the reduced amount of renal blood flow coming in this direction, there's a greater amount of glomerular filtration. So the GFR over the renal blood flow increases, so that filtration fraction increases. That's all that means. Now, all other things being equal, the fluid that escapes filtration over here in the proximal tubule comes over here to this vessel here surrounding the proximal tubular part of the nephron in the interstitial space. And because a greater fraction of what came at the glomerulus here got filtered, the so-called peritubular hydrostatic pressure is diminished. And because there's a little bit less fluid here, because more got filtered, the protein stays the same, the peritubular oncotic pressure goes up. So these so-called peritubular hydrostatic and peritubular oncotic forces promote augmented salt and water reabsorption in the proximal tubule, which is a cardinal feature of every clinical situation in medicine wherein there's either volume depletion or overt volume contraction or perceived volume depletion, as in heart failure. Now, this is a patient in the middle with primary aldosteronism. You all know what that is. Over here is a normal individual. The yellow boxes, this yellow box is the effective arterial blood volume. This is the extracellular fluid volume, depicted as being normal. Now, the next time you see a patient in your office with primary aldosteronism, you put your finger on the tibia, you don't get any edema. Isn't that interesting? Here's the primary aldosteronism. There's a tumor causing tremendous reabsorption of salt and water under the influence of a high level of aldosterone at this site. So there's increased salt and water reabsorption, and you get a mild expansion of the extracellular fluid volume. But the body doesn't like an expanded extracellular fluid volume. So the proximal tubule, which is really the big business end, says, boy, we're not going to reabsorb as much. So in primary aldo, even though there's all this increased salt and water being reabsorbed here, there's less salt and water being reabsorbed at the proximal tubule. The filtration fraction is going in the opposite direction. And so there's hardly any edema in primary aldo. Now, what happens in heart failure, which is the most classic example of secondary aldosteronism in clinical medicine? You all talk about increased renin, angiotensin, aldosterone. So this aldosterone motor is turned on, promoting expansion of the extracellular fluid volume. But the motor in the proximal tubule is also turned on because it perceives an inadequate circulation. And so this motor's turned on, this motor's turned on, and so there's tremendous expansion of the extracellular fluid volume. And if it gets into the lungs, they don't breathe very well, as you all know. And that's called heart failure. And that secondary aldosteronism is a cardinal feature of heart failure. So here we have chronic heart failure, decreased respiroreceptor sensitivity, increased activity of the sympathetic nervous system and the renin-angiotensin system, all promoting proximal sodium and water reabsorption with decreased distal sodium and water delivery. When you have decreased sodium and water delivery, that's associated with resistant to natriuretic peptides, failure to escape from aldosterone, sodium and water retention, increased cardiac filling pressure, perpetuating the chronic cardiac failure. So how might diuretics be useful or ultrafiltration in cardiac failure? Here we have congestive heart failure. Use a loop diuretic in the thick ascending limb of the loop of Henle, or ultrafiltration with a dialysis machine, producing negative salt and water balance, decreasing cardiac filling pressure, and of course, improving pulmonary congestion. The decreased cardiac filling pressure translates to decreased ventricular dilatation, decreased ventricular wall stress, and endomyocardial ischemia, decreased functional mitral insufficiency, improved myocardial function, and improved renal function, moving the GFR this way, and the serum creatinine would fall. Of course, as you know, a lot of these patients are resistant to diuretics. So what might be some of the possible reasons that these patients with heart and renal insufficiency are resistant to diuretics? Well, they could have an inadequate dose, things that we do wrong. Inadequate dose and increased dosing. Craig Brader has made his career on teaching us how to use loop diuretics to double the dose of furosemide, maybe until you get to 240 or 360. You start out with 40, it doesn't work. Then you go to 80, then you go to 160, then you go to 320. Okay, maybe probably stop there. Non-adherence, your outpatients not taking their loop diuretics or taking them, but then ingesting too much salt. Pharmacokinetic factors like slow absorption of a diuretic because of gut wall edema, impaired secretion of the diuretic into the tubular lumen from chronic kidney disease, aging. Non-steroidals are a big culprit in impairing the secretion of the diuretic into the tubular lumen. They have to get there in order to block the reabsorption of sodium in that thick ascending limb. Increased proximal tubular sodium reabsorption. So now you're beating up that patient with furosemide, increasing the dose, maybe you can give it to him intravenously, maybe even giving it to him tagged onto albumin, which increases the furosemide delivery of the thick ascending limb, where it's supposed to exert its blocking action for sodium reabsorption. And of course, the patient isn't getting any better. Well, there's two good reasons the patient isn't getting better. Remember that proximal tubular motor, just like I showed you in secondary aldosteronism, is just sucking up all of this salt and water. So less salt and water is getting to the Lasix site in the first place because it's being sucked up proximal. And then you have the situation where the Lasix works in the thick ascending limb, blocks sodium reabsorption. You get a little bit more sodium reabsorption going farther up the pike to that thiazide site. Well, it's dramatic that that thiazide site has a tremendous increased capacity to reabsorb salt and water. So it's not that the Lasix is a bad drug, it's just the next site in the nephron sucks up the sodium that was blocked from reabsorption at the thick loop of Henle. Hypoproteinemia, hypotension, low renal blood flow, neurohumoral activation, and nephron modeling. A year ago, I showed this slide. This was published about a year ago from the group at Oregon, demonstrating the relative contribution of compensatory distal sodium reabsorption just beyond the Lasix site and augmented proximal sodium reabsorption. And it turns out from some very elegant and sophisticated studies, the greater contributor is increased sodium reabsorption in the setting of loop diuretics to the hydrochlorothiazide site. About 3/4 of the compensatory increase in salt reabsorption in patients resistant to diuretics occurs there, and about 1/4 of it occurs because of augmented proximal sodium reabsorption. Well, the last physiologic point that I want to review with you is why do these patients get hyponatremic? Almost everybody with heart failure of any varying degree has some reduction in the serum sodium concentration. And without getting into all the renal physiology, a low serum sodium concentration means that a patient is in positive water balance. That's all. More water in than that got peed out. We nephrologists use this term free water. All that means, free water is a bottle of urine that you remove the solute from. That's called free water. And so in order to make free water, water has to be filtered at the glomerulus. It has to not be reabsorbed in the proximal tubule. It has to escape reabsorption, which it does in the thick ascending limb. That free water has to make its way to the end of the tubule so that eventually comes out in the final urine. And in people that get hyponatremic, they don't generate as much free water. They don't pee as much free water, and they keep drinking free water, or we give it to them, and their serum sodium concentration falls. But it doesn't fall tremendously. Most people with heart failure have serum sodiums, what, 131, 132, 133, 128. When that serum sodium is 119, 19, 20, it's the kiss of death. Why? Because these renal mechanisms are working so hard to protect a perceived inadequate circulation that the generation of free water is markedly diminished, and we keep giving the patient water and they get profound hyponatremia. This is a very old slide that I got from Alex Leaf when I was one of his fellows. Probably Jay Cohn remembers this slide as well from that classic article in the New England Journal, probably 40, 50 years ago. This shows the improved effect of cardiac function, improving cardiac function with digitalis on a reduced serum sodium concentration. Here's the patient with a serum sodium of about 130, just about right for your average patient with moderately severe heart failure. The fluid intake is being reduced, but the serum sodium concentration is in fact going down. The urine volume is very low. Now the patient is started on digitalis. Urine volume up, fluid intake down, serum sodium concentration comes right up. So the vicious cycle of chronic congestive heart failure is myocardial injury. In orange are the treatments. Depressed ventricular performance going clockwise, treated with digoxin. Reduced cardiac function. Neurohumoral responses, including sympathetic stimulation, for which beta blockers are useful. Renin-angiotensin aldosterone system activation, for which ACE, ARBs, and spironolactone are useful. Non-osmotic release of vasopressin, for which V2 or V1+2 receptor antagonists are being explored. Then you have renal salt and water retention, for which we use diuretics. Systemic vasoconstriction, for which we use vasodilators, all to decrease ventricular pre- and afterload, improve myocardial hypertrophy and ischemia, and try to correct the depressed ventricular performance, which is associated with heart failure and myocardial injury. So about 10 years ago, the Heart Failure Society of America guidelines said, when congestion fails to improve in response to diuretic therapy, the following options should be considered. From profound salt restriction, increase the doses of loop diuretics, which I've talked about, continuous infusion of loop diuretics, maybe tacked on to albumin that I've mentioned, addition of a second type of diuretic orally. So you got that loop diuretic Lasix there, and the patient's not responding. Now add a small dose of chlorothiazide, which is blocking that sodium that got blocked at the thick ascending limb, but it wants to get sucked up in the early distal tubule. Block that with metolazone or chlorothiazide or hydrochlorothiazide. We call that tandem use of diuretics, and then maybe add spironolactone to do the same thing. And then if that doesn't work, consider ultrafiltration. So in conclusion, cardiorenal syndrome is poorly defined and poorly understood. We need to better assess and understand the differential impact of arterial filling, renal ischemia, venous congestion, and intra-abdominal pressure on the pathogenesis of cardiorenal syndrome. Current strategies aim at salvage rather than prevention of deteriorating cardiorenal status, and that's what this whole meeting is about, cardiac prevention of bad cardiac things and are thus ineffective. Need better diagnostic and stratified biomarkers. Newer renal sparing approaches to salt and water removal are currently under evaluation, including modification of standard therapies with diuretics and vasodilators, vasopressin receptor antagonists, tolvaptan, lixivaptan, adenosine 1 receptor antagonist, rolifeline, BG, I don't even know what these are, BG 9928, SL320, maybe Mahfouz could tell us. Natriuretic peptide action, iseritide, you heard about one of them yesterday from Tony DeMaria, lulateritide, chimeric nitroprussides, calcium sensitizers, levomesandan has just been reported, and ultrafiltration. Now, ultrafiltration was really a big thing a while ago until a major controlled trial of ultrafiltration versus better medical management with the diuretics was published and showed that ultrafiltration was no better than a judicious use of diuretics. And the editorial that accompanied that paper by my colleague Wilson Tang went on to say this: we may even have to confront the possibility that the pressure to reduce hospital length of stay with a strategy of initial aggressive diuresis in patients with acute decompensated heart failure may actually result in an increased incidence of the acute cardiorenal syndrome and cause unwanted consequences. Perhaps slow and steady, a few extra days in the hospital to more gently unload the salt and water with judicious use of diuretics may win the race after all. I thank you for your attention, and I hope, Mahfouz, I stuck to my 20 minutes. Thanks very much.